Hello and welcome to another Unfiltered production podcast. And you've got Sherry Teague and Cindy Kraft. And we have a really interesting topic today. We speak a lot on maintenance therapy. We were in Raleigh at the North Carolina State Association's annual conference. And yes, it was the first one out the gate, the first one we were in person. And it was sitting there watching Cindy present on maintenance therapy and watching her rant on and on about maintenance therapy and why maintenance therapy is so important and why agencies should implement maintenance therapy today, not yesterday, was really interesting to me because I've been hearing her and Dee Cornetti speak on this topic since 2013. So for 9 years, I've heard uh, probably at least 10 or 12 sessions on this a year from them. And we still get some of the same questions about maintenance therapy that we got on day one. So, Cindy, I wanted you to share what it was, the epiphany that we came to just before this conference that you shared with the audience. And then we can talk about how we had that verified.
Well, you're right. We've been talking about this for 9 years, and I'm not trying to be disrespectful to people that are exploring this option, trying to learn how to do this, incorporate it into their agency. But reached a level of frustration because now it's like, okay, so 2011 was the Jimmo decision. We're more than 10 years later. And it's still, well, I might do it. Well, I don't want to. I mean, I'm hearing that as well. It's, okay, I understand it, but that's just not my thing. Either as an organization, we're not going to do it. We don't see the need for it, or an individual therapist saying, I just don't want to do that. That's not something I'm interested in. And it's just been boiling in me over the last several months to the point where it's like, okay, I don't want to argue with people. I really don't. The facts are the facts about what the beneficiary is entitled to. So the analogy that popped into my head was, okay, so as a provider, I can say I am not comfortable or competent in doing wound care. Okay, so I can say for my home health agency, we are not doing wound care. You can absolutely say that. But if a patient presents themselves, you've got this referral and there's a wound on them, you can't just turn a blind eye to it and say, we don't do wounds. I mean, we are obligated by regulation to tell this person, we do not provide that level of care that you need, and help to facilitate a referral to another organization that can provide that level of care. So, what is the difference between that and maintenance therapy? I mean, if you have a patient who clearly qualifies for home care, absolutely meets the coverage criteria for maintenance therapy. Everything is there that needs to be there. How can we keep saying, well, I don't know. Well, I just don't think so, or I'm not going to, because why would that not be the same standard of that's fine, you don't have to provide maintenance therapy, but you have to be educated enough in it that when you identify those needs for patients, then you need to refer them to a home health agency that will provide the maintenance therapy. Well, after that rant, and Sherry and I talked a little bit, I said, because that's the only example I can think of to try to pivot the conversation away from let's just keep discussing it for 10 more years to you are obligated by the benefit to either get in here and do it or find them somebody who will. And we had the opportunity sitting in the exhibit hall to interact with someone from Palmetto, one of the big intermediaries. Many folks know that name. And so we pitched the question and just said, are these equivalent? The wound care example and maintenance therapy. And looked us dead in the eye and said, yes, absolutely. If they are entitled to that and then qualify for that and you don't provide it, you are supposed to refer them to someone who does. So it was a moment that said, okay, first of all, I'm not crazy. um, but we do have to have that level of passion about this topic. I think the time for let's just put it on the radar and maybe get to it eventually, that has passed. I think 10 years in, we need to either commit to I need to get my house in order and make sure that I have staff prepared to do this. We're properly identifying patients. Or, as I said, where am I going to send them? And it's not an excuse because I've heard this one, Sherry. Well, nobody around us does that. Nobody else around here does maintenance. So where would I send them? That's not an excuse. That's not a way to go, well, the patient really wouldn't want to be transferred. So even if I offered another provider, they'd probably decline it. Okay, But much like in the ALF setting, when we get scrutiny for how come they didn't get an aid, they're paying for an aid as part of being there. Aid is part of the bundled services, and you didn't give them one. Well, they wanted to keep theirs. They can do that, but you have to document that you offered it to them and they declined it to keep the aid they have. So I would argue, kicking this up a notch while I'm talking this morning, Sherry, is even the argument that, there isn't somewhere else to send them for maintenance. I would say I would still need to document that I understand this is what they need. I do not offer this. They declined to go to another provider, because then it's the same issue across the board. I'm still obligated to honor the benefit. The patient still has choice, but this kind of whole I don't really want to do it and nobody around here does it thing, I don't think it's going to hold water. And to have Palmetto say that those things were comparable was like, yeah, we're not nuts. We
And
need to
I'm
get
gonna
this off the starting blocks and moving forward.
and I just want to add one other thing. I mean, that includes disciplines that you don't have coverage for. If you don't have
Hmm.
OT coverage, you don't have speech coverage, obviously we need to send them out. And there was another point of clarification we made as well, Cindy, about other disciplines saying that a patient doesn't need the other discipline. Very clear instruction: no, that nursing cannot come in and say they do not need physical therapy based on their assessment, unless the patient refuses or there's a patient safety issue that's documented with the physician. So these kinds of things, guys, these are the rules. These are the rules of the game. You can't shift your. I think about that. The coconut thing with the ball, where you shift all your services and try and dance around the regulations. The regulations are the regulations, and GEMA was decided more than 10 years ago. And every time that it tries to be denied, the lawsuit moves forward, and there's another lawsuit that's drawn up. Maintenance is part of the benefit, period. It's part of the benefit that's owed to our Medicare beneficiaries in the home setting. And Cindy, these are epiphanies that we come to. And one of the other ones that you mentioned during your speech that I think that we need to say is that whether you think you're doing maintenance therapy or not, oh, but you are. You want to
Oh yeah.
expound on that a little bit?
I do believe, for all of the maintenance deniers, as it were, um, you all therapists are providing some degree of maintenance. And this is where, yes, we're on a rant today, but we're trying to get people unstuck, because I do acknowledge that for therapists, this is a difficult transition. When your entire career has been based on I need to improve people. And if I am unable to improve their function, I am obligated as a good therapist to discharge them. That reaching a plateau is a bad thing. And once they're, hit it for a few days or treatment visits or whatever, I have to discharge. To find out all of that was basically a lie is painful. And it's difficult to make that mental transition. But in reality, we've been doing this. We've had patients where, we believe that there's a reasonable expectation for improvement. They make this improvement as we near our goal completion. We know we're done. We know that there's no reason to continue to see them. They will probably continue to progress when we're done, because they have the tools and things that they need to continue on this path. They just don't need me anymore. But there's always been on our caseload this little subgroup of patients where we did start out on the restorative track. We do expect improvement. But as we reach the goals or get near the goals, we are a little skeptical that, yes, they've made gains, but I'm not sure it's sustainable. I'm not sure that plateau is stable. Yes, they've gotten to the plateau, but I'm not ready to leave yet. And this is not about cheerleading them to do things or they won't do it if I don't come. This is, I am professionally concerned that if I leave now, this may go sideways. And so this is where I see it time and time again in the documentation, the original trajectory of improvement. And then there's these last couple weeks of care that either don't show improvement anymore in the technical sense, or try to squeeze out, I'm sorry, ludicrous kinds of improvement, like increased strength a quarter grade. I mean, how did you even do that or measure it for real? Or they took 2 more steps. Okay, to what? I mean, it's more than when you did before, but what is materially significant, functionally relevant about what you're saying? And that's where we've seen a lot of historical denial, Sherry, is not that the whole therapy got chucked, but the last part of it did because they weren't showing improvement. And we took that as validation of yes, we have to be about improvement. When reality is those last couple weeks, that's called maintenance therapy.
Hmm.
You were trying to stabilize function. You had a very valid reason that your skills were essential and reasonable and necessary to stabilize the gains they've made. The problem is we don't feel comfortable calling it that, so we don't. The documentation still tries to talk about improvement, even though that's not actually happening. And our goals still read the same. And then we add insult to injury by we use the billing code that says this is all about improvement. And so even with GMO, we've teed ourselves up for denial risk saying, you told me this was improvement the whole time. The last 2 weeks it flattened out. I'm not paying you for that. So we're doing it. We have to make sure we know how to document it, and we have to make sure that the billing's being done correctly.
And to tell you how CMS is leaning into this benefit, last year they allowed assistants to begin providing the maintenance therapy visits. And Cindy, I'm gonna lean into that empathetic thing where you said that as therapists we've been addicted to improvement. We've been taught improvement. We were actually taught the word maintenance was a bad word, along with plateau and several other words. Endurance was another one that we couldn't use. So we actually changed the wording a little bit and started talking about stabilization, and that might have people a little bit more ready to lean into the maintenance. But CMS is leaning into it, guys. They're looking for this as a change in how we customize and individualize plans of care for the beneficiary. They know that 80% of seniors want to live in their home. They want to stay in their home. They also know that there's a silver tsunami that's happening. And every year we have more and more beneficiaries that are 65 and older that are crowding facilities. Facilities are under the microscope because of some of the things that happened during the pandemic. There is a plethora of reasons why maintenance therapy and us being this aggressive about being realistic in your home health setting and providing this benefit is so important as we go into 2023 and as you go into tomorrow. I mean, query your therapist. Do you have any folks that you know if you discharge, they will decline? And I guarantee you, they will put their hand in the air and say, "Yes, I do." But Cindy, did you have any other thoughts before we close out?
Well, the one nugget I would also like to tack on to this conversation is to also take a hard look at management and evaluation for nursing. Because a lot of the concepts, when we talk about maintenance therapy, the nurses there will suddenly be like, wait a minute, this sounds like parts of management and evaluation. And it's like, yes, another part of the benefit that went from robust utilization to overutilization, we got denied to nobody's ever heard of it. I mean, I meet nurses now who've been in this setting for years and don't know what management evaluation is. So we kind of hit it. Do I think that they're doing some elements of management evaluation just like I think we're doing maintenance? Yes, I do. And I think it's time to look at all elements of the benefit for all disciplines and say, what are we doing? Are we prepared to provide this? Do we need to seriously say, well, we're not going to, so how do we refer them elsewhere? Because I think we've gotten very narrow in what we define as skilled, reasonable, and necessary. And now we're omitting parts of the benefit, which again, the Palmetto guy was very clear. You can't do that. So I think the time has come to kind of look at it and make some decisions about what are we going to do going forward.
So as we close out, I want to remind everybody that the title of this one was Maintenance Therapy Rant and Warning. I think we cleared the rant part, Cindy. The warning part is if you're not providing this benefit and your beneficiary, your patient needs this benefit, then you have to refer them to someone else per guidelines, per the advice that we received from the Palmetto beneficiary representative. So this is an owed benefit to our patients, and we need to provide it in our agency. I want to thank you for attending this and listening to our Unfiltered podcast. If you guys have anything that you would like to rant about, please reach out to us. We want to invite folks that have a situation happen in the field that maybe we're not aware of. We're not in the field every day. We would love to hear what things stick in your craw, as a Southern colloquialism that I can share with everyone. If it sticks in your craw, get on Unfiltered Productions and join us for a podcast. And also subscribe to our YouTube channel where we post all of our free material and we have some really great information on there. Cindy, do you have anything else before we go?
Nope. I just hope that we've motivated some folks to think about this. And if you need any assistance or additional information to get your program off the blocks, please reach out to K and K. We'd be happy to help.
Thank you and have a great day, guys. Be safe.